Follow-up after NET surgery, surveillance imaging schedules. Hello, this evidence-based content is prepared by Saboor Khan, fellowship-trained consultant surgeon, and if you or someone you care about has had surgery for a neuroendocrine tumor and you're wondering what comes next, you're in exactly the right place. I know that finishing cancer treatment can feel like stepping off a cliff. The regular contact stops and you're left wondering, how will they know if it comes back? Today we're going to walk through everything you need to know about surveillance after NET surgery. Before we dive into the schedules, let's quickly establish what we mean by surveillance. This isn't about living in fear. It's about smart, evidence-based monitoring designed to catch any problems early when they're most treatable. Neuroendocrine tumors can sometimes recur even years after successful surgery. We've documented cases recurring 15 years later. But here's the important part. With the right surveillance plan tailored to your specific situation, we can detect these early and act decisively. Now, what about your personal surveillance plan? Here's where it gets interesting. Not everyone needs the same follow-up schedule. Let me walk you through the 3 key factors that determine what you need. The grade of your NET, whether it's G1, G2, or G3, fundamentally changes your surveillance strategy. Think of it like this. G1 tumors are the slowest growing, G2 are intermediate, and G3 are the most aggressive. If you had a completely resected grade 1 NET without lymph node involvement, you're looking at yearly abdominal MRI or CT scans for at least 5 years. For G2 pancreatic NETs, imaging happens every 3 months initially, then can extend to 6 monthly intervals. For G3 tumors, we start with 3 monthly imaging intervals for the first 2 years. Here's something that might surprise you. Even after 5 years of being tumor-free, we don't just stop watching. The surveillance intervals can be prolonged to yearly, but we maintain vigilance because late recurrences do happen. If you had a gastric neuroendocrine tumor, specifically a small type 1 GNET that was completely removed endoscopically, you'll need endoscopy follow-up every 12 months after resection. Now you might be wondering why endoscopy and not just scans. That's because these gastric NETs sit in patients with chronic atrophic gastritis, which itself carries about a 1% yearly risk of developing gastric adenocarcinoma. So that endoscopy is doing double duty. For rectal NETs, the picture is quite different. If you had a small rectal NET, less than 1 centimeter, grade 1, completely removed with no vascular invasion, you actually don't need routine follow-up. The recurrence rate up to 2 years is close to 0. However, if your rectal NET had any risk factors, vascular invasion, grade 2 features, or was larger than 1 centimeter, you need 6 monthly MRI scans and yearly colonoscopies for at least 5 years. Small intestinal NETs demand the most vigilant follow-up. These require imaging every 3 to 6 months after surgery, followed by 6-month intervals for G1 tumors and closer intervals for G2. The liver is the most frequent site of distant metastasis, which is why abdominal MRI is preferred. It's more sensitive than CT for detecting small liver metastases and doesn't expose you to radiation each time. This is critical information that every patient should discuss with their surgeon. An R0 resection means clear margins. All the tumor was removed with healthy tissue around it. R1 means tumor cells were found at the edge of what was removed. If you had an R1 resection of a small rectal NET and a second procedure isn't possible, you need endoscopy and endoscopic ultrasound, or MRI, monitoring every 12 months for at least 5 years. This isn't about scaring you. It's about being appropriately vigilant. You'll hear about several different imaging types, so let me break down what each one does. Conventional CT or MRI scans show us the anatomy, where tumors are, and how big they are. For pancreatic NETs, abdominal MRI with diffusion-weighted sequences is preferred because it's more sensitive for small liver metastases than CT scans. Then there's functional imaging. This is the game changer for NETs. Gallium-68 DOTATATE, or DOTATATE PET, scans light up neuroendocrine cells specifically. The data reveals that this should be performed 3 to 6 months after curative surgery, then every 12 to 24 months if you were initially receptor positive. This is particularly important for colonic NETs with initial stage 3 or 4 disease, where we recommend 6 monthly conventional imaging plus gallium PET every 24 months. For higher grade tumors, G2 approaching G3 or actual G3 NETs, we add FDG PET scans. These detect areas of high glucose metabolism, which faster growing tumors show. Research demonstrates that FDG PET provides crucial prognostic information in these cases. Now let's talk about what happens at each visit besides imaging. Chromogranin A, often abbreviated as CGA, is a protein secreted by neuroendocrine cells. The plasma level of CGA correlates with tumor burden and can be monitored using the same assay kit throughout your follow-up, and that last part is crucial. Different assay kits have different cutoff levels, so you need consistency. CGA should be measured at the time of first diagnosis as a baseline, then reassessed at 3 months and in parallel with your imaging schedule. Here's something important to understand. CGA levels can be elevated in several non-malignant conditions. impaired liver or kidney function, atrophic gastritis, inflammatory bowel disease, and even taking proton pump inhibitors for acid reflux. So an elevated level doesn't automatically mean recurrence. If specific symptoms increase or new symptoms appear, we recheck biomarkers regardless of the schedule. In long-term follow-up, if your CGA is informative, meaning it was elevated when you had measurable disease, we may use it alternating with imaging, and a significant increase prompts additional diagnostic workup. For higher-grade NET G3 tumors, neuron-specific enolase levels can be useful as an additional marker. So here's your bottom line. Let's talk about the 3 categories of action you can take. First, create your personal surveillance calendar. Work with your healthcare team to map out exactly when each test is due. Put these appointments in your phone calendar with alerts 2 weeks before, so you can schedule around work and family commitments. Don't wait for the hospital to call you. Take ownership of your schedule. Second, request copies of all your pathology reports and keep them in one place. You need to know your tumor grade, your resection status, whether lymph nodes were involved, tumor size, and whether vascular or lymphatic invasion was present. These details determine your entire surveillance plan. Third, if you're on proton pump inhibitors like omeprazole or lansoprazole, discuss this with your doctor before chromogranin testing. These medications can falsely elevate CGA levels, potentially causing unnecessary anxiety. Come to your appointment with these specific questions written down. What was my exact tumor grade and stage? Do I need conventional imaging, functional imaging, or both? How often should my Chromogranin A be checked? What symptoms should prompt me to call between scheduled visits? Request clarity on the duration of surveillance. For most NETs, follow-up should last a long time. It may be required to be lifelong after resection, since disease relapse can occur even 15 years after surgery. If you're supporting someone through this, ask, what signs of recurrence should family members watch for? Subtle symptoms like persistent flushing, new-onset diarrhea, or unexplained abdominal pain deserve evaluation, not dismissal. If you develop new or worsening symptoms between scheduled visits, don't wait. We're talking about persistent new abdominal pain, unexplained weight loss, new-onset flushing or diarrhea, or any symptoms that were present before surgery returning. In patients with suspected recurrence showing rapid or unexpected progression, imaging-guided biopsy should be considered to reevaluate the Ki-67 proliferation index. That's the measure of how fast cells are dividing. An increase may change the treatment strategy. For rectal NETs specifically, if you had an incomplete resection and new lesions appear on surveillance endoscopy, biopsy and discussion of further endoscopic or surgical resection is essential. Let me quickly recap. Your follow-up schedule after NET surgery depends on 3 main factors: tumor grade, location, and completeness of resection, with higher-grade tumors and incomplete resections requiring more frequent monitoring. Your next step: schedule a consultation with your surgical team to confirm your personalized surveillance plan based on your specific pathology. This information is for education. Always discuss your individual situation with your healthcare provider. I've outlined several reputable resources here, which you may find valuable for further information on this topic. These include the European Neuroendocrine Tumor Society Consensus Guidelines, the 2023 ENETS guidance papers for gastroduodenal, pancreatic, small intestinal, and colorectal neuroendocrine tumors, and the ENETS consensus recommendations for follow-up and documentation published in Neuroendocrinology. All links are available in the description below. Thank you for watching.